Hello and welcome to another edition of Cardiac Imaging Agora. In this session, I have the honor of presenting my colleague and good friend and partner, Dr. Paul Kremer. Paul is a fantastic friend, and he's a associate director of the fellowship program, as well as the associate director of the cardiac intensive care unit at the Cleveland Clinic. Paul is a true multimodality imager. He's trained in echo, CT, MRI, nuclear imaging, advanced PET imaging, in addition of being a fantastic clinical cardiologist. And he's going to give us some insights about the role of CTA in suspected and known endocarditis. Paul?
Excellent. Thank you, Dr. Jaber, and thank you for that kind introduction. I've certainly learned a lot of cardiology and cardiac imaging and general life lessons from you over the years, and I'm very excited to be a part of this program. So what I'm going to talk about is the role of CTA in suspected and known endocarditis, and this has really emerged over the past several years, and something that we're using more and more as we become more and more familiar with the modality. I would also say that in the current COVID-19 pandemic, where we're minimizing the use of certain procedures such as transesophageal echo, it may be particularly relevant in that setting as well. So I'd like to start just by asking a couple questions. The first is, how should we think about endocarditis as cardiovascular imagers? And how does this framework inform the additive value of CTA in certain patients? So that's really what the beginning of my talk will focus on. And then I'll conclude by highlighting some case examples where I think CTA has really been helpful in our patients with infective endocarditis. So we know that there's many ways to think about classifications in endocarditis, from the classic Oslerian mindset of subacute versus acute, community-acquired versus healthcare-associated, whether it's intravenous drug users or according to the microbiology, the Staph aureus, non-Staph aureus, enterococcus, streptococcus, et cetera. And those clinical classifications are extremely helpful for us as cardiologists and as clinicians. However, as imagers, I think it's more helpful for us to think about the anatomic classifications when we're reviewing our studies. And that can include native or prosthetic or cardiac device related, left versus right-sided disease, or invasive versus non-invasive disease. And I'm going to focus primarily on invasive versus non-invasive disease, because I think it's probably the categorization that we're least familiar with. And I think it's probably the category where CTA is most useful. So the ESC has an excellent guideline document on endocarditis, which I encourage you all to read. But in terms of thinking about the anatomic considerations, the surgical guidelines are also very helpful and informative. And what the surgical guidelines do is they provide us with a standardized approach to define pathology. So we're going to define invasive disease as when tissue disintegration involves the valve annulus and infection invades extracellular areas. So this is essential to understand the extent of the invasion because it does, for the surgeons, inform appropriate debridement and reconstruction approaches. And like any infection, we can stage the disease, and endocarditis is no exception. So it usually begins with, we think about invasive disease as cellulitis, and then as that coalesces to form an abscess and then an abscess cavity. And that abscess cavity can then become endothelialized without pus and form a pseudoaneurysm. So when I'm looking at a transesophageal echo or a CTA, and it's a patient who I think has an invasive complication related to endocarditis, I'm thinking, where are they in terms of this progression? So I think an initial question is, how common is invasive disease? So this is a study from our institution of over 1,200 patients who had surgery for endocarditis. And the first point that I would make is that invasive disease in right-sided endocarditis is quite rare. is fairly uncommon, less than 1% of the cases. However, in left-sided disease, it's more common. So at least in patients that go to surgery, about 2/3 of patients with aortic valve disease will have an invasive complication, so an aortic root abscess or a pseudoaneurysm or a fistula. And about 1/3 of the patients with mitral valve disease will also have invasive complications. And then if you have aortic and mitral, then that increases even a bit more. I would say mitral is actually an area that it's often difficult to image in terms of looking for abscess. So that this number may actually be an underrepresentation, but suffice it to say that invasive disease is extremely uncommon with right-sided endocarditis, but fairly common in left-sided disease, especially when it involves the aortic valve. The second point to emphasize is that invasive disease is essentially the norm when you have a prosthetic valve that at least has a surgical indication. So again, this is the same cohort of patients who went for surgery. And you can see that in patients who had aortic prosthetic valve endocarditis, over 80% had evidence of invasive disease. So it's common with left-sided disease and particularly common with prosthetic valve endocarditis. So what I'm going to do next is sort of summarize the test characteristics from numerous publications that have looked at the role of CTA in imaging infective endocarditis. And what I'd say is this is just to give a general broad overview of what we think in terms of diagnostic accuracy. Because these studies are quite heterogeneous and span, from 2009 to 2019. And over the decade, there's been a lot of advancements in our CT protocols and how we can optimize and assess these patients. So there's a lot of heterogeneity there. So this is simply to give you a sense of how CTA performs in the assessment of these patients. So I'm going to look at the CTA test characteristics compared to surgery as the gold standard. Obviously, there's some selection bias because not all patients will go to surgery. But again, I think this gives us a sense of how CTA performs, especially as it relates to in relation to transesophageal echo. And so we'll sort of categorize this in terms of looking for vegetations, looking for invasive disease, and then looking for prosthetic valves. So if we look at vegetation, so I combined all the studies that were mentioned that assessed for vegetations. And so this was 259 patients. And you can see that CTA had a sensitivity of 84% and a specificity of 89%. So not great, but not bad either. The performance improves if you look at the patients who have invasive disease. So this is aortic root abscess, abscess cavity, or pseudoaneurysm with a sensitivity of 92% and a specificity of almost 99%. And improves even further if you look at the subset of patients who have prosthetic valve endocarditis involving the aortic valve. So in this cohort, and it's a smaller number of 91 patients, the sensitivity was 98% and it was 100% specific. So we can see that CTA doesn't perform as well with vegetations, but performs better when we're looking for invasive complications, and particularly well if we're looking for invasive complications related to prosthetic valve endocarditis. Now, to a certain extent, CTA and TEE may be complementary. So this was a study that, a small study, but interesting and informative in that it just asked the question of which modality provided the indication for surgery. And you can see in some patients, the CT and TEE both had indication for surgery. In some patients, it was the TEE only, and in some patients, it was only the CT. So there may be patients who can or would benefit from a transesophageal echo and a CTA. And I think we're going to learn more about this in the years to come. And I think it will, in large part, end up being an individualized patient decision. But a couple of generalizations. I think given the fantastic temporal resolution of transesophageal echo, echo is better at identifying vegetation, small fistulas, and leaflet perforations. Given the anatomic spatial resolution, and in particular the larger field of view of CTA, it's often better at identifying the extent of invasive complications. Okay, so I'll conclude just by showing some case examples. So there's different protocols. What we generally do is we have an endocarditis protocol. And in most patients, that ends up being a full retrospectively ECG-gated acquisition of the heart, so a 4D of the heart. In the older patients, we tend not to use dose modulation because we're not as worried about the radiation dose. However, in the younger patients, we may use ECG dose modulation, or we may use a single phase acquisition scan. But in general, we're going to do a retrospectively ECG-gated study of the heart for 4D assessment. And then we follow that with our system, with our scanner, with a prospectively ECG-triggered high-pitch spiral acquisition of the entire chest. So that's helpful for defining the relationship of the cardiac and vascular structures to the sternum in patients being considered for repeat surgery. And also, as I'll highlight, for recognizing complications related to endocarditis that may be out of the field of view of what you would usually see in a heart or in a 4D CT that's just limited to the heart. So namely involving the ascending aorta. So here I've reconstructed this in views that were sort of similar familiar with looking at in echocardiography. So a similar sort of short axis view of this is a patient with a prosthetic aortic valve. And you can see this heterogeneous attenuation here. So this is this anterior root abscess. And you see these hypoattenuating densities here prolapsing into the left ventricular outflow tract, compatible with vegetations. And here is that aortic root abscess that's sort of surrounding the right coronary artery there. Okay, so here's another example. This is a patient who has a bioprosthetic mitral valve, but what you're actually seeing here is a large pseudoaneurysm involving the aortic root. And then here on this 4D reconstruction, you can appreciate this aortic root pseudoaneurysm that's immediately inferior to the left anterior descending artery. So CT really delineates fantastically the anatomy and the relationship to the other structures of the heart. So here's a patient who's had prior aortic valve and mitral valve replacements with bioprostheses. And so here you can see this bioprosthetic aortic valve with these abnormal hypodensities. You also see these contrast-filled outpouchings compatible with aortic root pseudoaneurysms. And you also see this contrast-filled outpouching here posteriorly. And if you reconstruct this, you can see this abnormal thickening and vegetations on the bioprosthetic mitral valve. But you also see this pseudoaneurysm here, sort of lateral or inferolateral to the bioprosthetic mitral valve. And so this would be potentially a bit difficult to visualize with TE. And again, the CT really highlights the pathology quite clearly. So this is a patient who also has a bioprosthetic aortic valve, and you see this large aortic root pseudoaneurysm. So again, it's this big contrast-filled outpouching. So that abscess cavity has ruptured and become endothelialized. And you can appreciate that here on the reconstruction. But the other thing that this case shows nicely is the abscess involving the aortomitral curtain, the aortomitral intervalvular fibrosa. And this is certainly important to document as an invasive complication because of the surgical implications. So usually this will require what we call a commando procedure, which will involve replacing the aortic valve, repairing or replacing the mitral valve, but also reconstructing this aortic mitral intervalvular fibrosa. Now, this is a younger patient, so you can see that we did actually use ECG dose modulation for this study. As you can see, some of the phases are a bit noisier. So this is a slide courtesy of one of our surgeons, Dr. Unai. And here you can see that there's basically a circumferential aortic root pseudoaneurysm. And he described to me that often the valves like this are nearly completely dehisced and can be kind of pulled out with only cutting a couple of sutures. For us as imagers, I think where CT is helpful is that with echo, sometimes we can be troubled with shielding from foreign material, such as bioprostheses. So if we're doing a transesophageal echo, we may not be able to see anterior to the bioprosthetic aortic valve all that well. So that's actually an important point where surface echo can be really helpful in terms of if there's an anterior aortic root abscess or pseudoaneurysm. You may appreciate that on a transthoracic echocardiogram and miss it on a TEE, but certainly you appreciate the extent on a CT scan. So here's an example of a fistula from the left ventricular outflow tract into the right atrium and right ventricle with a beautiful corresponding image on a transesophageal echo. This is what we call an acquired Gerbodi defect. And again, the infection often does in endocarditis spread along the fibrous skeleton of the heart. So as we saw, it can involve the aortomitral intervalvular fibrosa and also can extend and result in this Gerbodi defect we see quite commonly. So here's a patient who had multiple prior cardiac surgeries, has a homograft, and came into our, I was caring for him in our ICU with Staph aureus bacteremia. And here's the site of prior aortic cannulation. So that had become super infected, and there was a contained rupture there, which you can appreciate here. And you can also see on this sagittal reconstruction. And so this is just simply to show that there's really no way that you'd be able to see this with a transesophageal echo. So in particular, if you're worried about pathology involving the ascending aorta, such as patients who've had prior aortic graft replacement, CTA is very helpful. And this is courtesy of Dr. Jose Navia, showing that perforation at the site of prior aortic cannulation. Okay, and then the ancillary uses. So often these patients, especially if it's not an emergency, will need some assessment of their coronary arteries, and coronary CTA can be very helpful. So they may be coming to your scanner for a preoperative coronary CT angiogram, and you're also able to define the pathology related to the endocarditis quite well. So this is the case that I showed earlier of that aortic root pseudoaneurysm sitting sort of just inferior to the LAD. And I think on this 3D virtual reconstruction, you can appreciate that quite well. And endocarditis is a systemic disease. So the patients may be coming to your CT scanners for coronary CT angiography, or they may be coming there for other complaints such as abdominal pain. So here's a hypodensity in the spleen, so a splenic infarct, which we see very commonly in endocarditis. Here's a hypodensity involving the right kidney, so renal infarct. And unfortunately, they can embolize to their visceral and pelvic arteries as well. So here was a patient that I took care of who had enterococcal endocarditis that ended up having an occluded common iliac artery. And here's a patient who had an embolus to the SMA. And finally, especially in the setting of right-sided endocarditis, we often see a large burden of septic emboli and pulmonary abscesses. And the most feared complication, of course, are the CNS complications. And here's a hemorrhagic conversion of an embolic stroke. So to conclude, I would say that invasive disease, so abscess cavity, pseudoaneurysm, in the setting of endocarditis is fairly common in left-sided disease, especially involving the aortic valve, and may in fact be the majority of cases in prosthetic valve endocarditis, though a lot of that depends on where you're practicing and some referral biases that may be involved in your institution. As a general comment, TE is better for vegetations, leaflet perforations, and visualizing fistulae, whereas CTA is better for the invasive complications of abscess and pseudoaneurysm. In certain situations, these modalities may be complementary, and I think a lot of these decisions can be individualized based on the input of the endocarditis team, which is another important point to emphasize, is that as cardiovascular imagers, we're really part of a team involving the clinical cardiologists, the infectious disease experts, the cardiac surgeons, and with some of the complications, we may need neurologists, neurosurgeons, vascular surgeons. And so these patients are really complex and should be approached in a team-based care. And finally, CTA may be helpful for additional ancillary indications, such as assessing the coronary arteries preoperatively, looking at the relationship of cardiac and vascular structures to the sternum before reoperative surgery, and investigating causes of systemic embolic phenomena. Excellent. Well, thank you again for having me, and I very much have enjoyed this program. Thank you.
Oh, I thank you so much. This is a fantastic overview of not only putting what we do actually, as you always tell me, we are just imagers to answer a clinical question. We're not imagers in the abstract, and that actually here proves that what we do is very much clinically oriented. I have just two simple questions for you. The first one is, so most centers in the country and the world are used to CT for the heart for coronary arteries. How much of a protocol modification you have to do to end up with the images you got for this indication, and how much do you have to know a priori before you get the patient in the scanner?
No, I think most places that are doing coronary CTA up to the per standard guidelines from the professional societies, I mean, I think that protocol will highlight the invasive complications quite well in terms of looking for abscess, looking for pseudoaneurysm, the contrast bolus timing, most of this is left-sided disease, so that will all be the same. It's worth noting that often these patients are quite ill, so we're not usually, we may be less likely to beta block these patients or give them nitrates and the sort of similar pre-medication we might use for coronary CTA. But that said, I think, usually we're able to get diagnostic images for the coronaries. I think some of the more subtle findings in terms of picking up a smaller fistula or looking at a smaller vegetation, there you probably do need, at least I found when we transitioned a couple years ago to a higher end scanner with an improved temporal resolution. I think for looking at vegetations and looking for maybe a small fistula, we do see that better. But again, I think echo, that's the advantage of echo. But yeah, but I would say with a typical coronary CTA protocol, you would pick up most of these invasive complications involving, for example, the aortic root.
Thank you. The second question I have before I let you go, I know we imposed a lot on your time, but during these busy times, is how much have you seen in the past, at least at our center here in Cleveland, how much have you seen a shift in requests for CTA for this indication from TEE to CT? I know it's very hard to quantify that, but have you seen an increased demand to avoid doing TEEs in the era of COVID, in the era of limited testing for COVID-19? Have you seen that shift, or we're still doing the same number? Or it's very hard to answer, I understand, but have you seen at least a different pattern of practice?
Yes, so I think that's right. I think in with the current concern with COVID, we like so many places are really screening carefully which patients are needed to have a transesophageal echo. I would say even before COVID, over the past couple years, this is anecdotal and not based on any data, but hopefully that will be forthcoming, is I would say that often I think the clinical question is answered with a good surface echocardiogram for the hemodynamic assessment of what's going on with the patient. And the CTA that we do for the endocarditis protocol. So I have a lot of cases where the patients have had a surface echo and a TE and a CTA. And when I go back and look at all this, I say, you know what, the TE really didn't add a lot. That's my own bias. And I would say, again, as I mentioned, for example, in the patient who has had prior cardiac surgery, who has prosthetic valve endocarditis, they're going to be, at least at our institution, coming to the scanner anyway for a CT scan for preoperative planning. Mm-hmm. So if the patient has normal renal function and there's not really a downside to giving intravenous contrast, I think it makes a lot of sense to just do a further assessment for endocarditis as well in that setting.
Thank you so much, Paul, and thank you. Hope you have a nice weekend, and we'll have you for sure for more sessions. We'll impose on you. Thank you so much.